And so Deed, who is the lead instructor and lead researcher for Chiropractic BioPhysics, had asked me to start teaching the classes on CBP at Life West, which is where I graduated from. And I did that very happily for a couple of years, which was interesting to me. I never thought I would ever step foot back into that school once I graduated. Because I remember being in your guys' seat and thought for sure, once I'm done, I'm never coming back. But when Yoda asks you to, step up and do something for him, you kind of have to say yes. And I was pleasantly surprised that I actually enjoyed teaching. Really teaching makes you understand something at a much higher level. And after a couple of years of doing that, I decided that it was time for me to move back to my home state of Colorado and start another practice. And when I did that, my business partner in San Francisco took over the class at Life West. And I asked Deed, I said, I want to still contribute to CBP. I know nobody's going around to the schools very often. I'd like to put together a webinar series, and I'd like to go out to the schools if you would like me to do that. And so that's what I've been doing for the last year. I've really been enjoying it. This is my first time to your guys' campus, which I'm really excited about. So let's get into it here a little bit. I put a couple of pictures of my practice into this just so that you could get an idea of what does a CBP office look like. They all look a little bit different, but this is part of the one that we have in San Francisco. When I started practice, we had put together our business plan, which was very detailed. My background before chiropractic was in business and economics. And so I had spent a lot of time putting together what I believe to be a very solid business plan. And we got it back from the printers on the day of the record stock market crash in 2008. And thought, boy, that's not good. Because we couldn't get a single bank to even look at it to consider giving us a loan. So my business partner and I rented a 150 square foot office, which is about the size of a walk-in closet, and had an Astrolight adjusting table, impulse adjusting instrument, and a set of blocks. And I started building traction equipment and doing the best that we could for our community, and started getting some referrals pretty rapidly, started knocking down walls, and over the next couple of years we ended up having about 3,000 square feet in San Francisco. We've got a multi-departmental office. I've got a big, huge emphasis obviously on structural healthcare and CBP specifically, but I also think that nutrition is extremely important, and so we have an aspect of our practice that is solely focused on nutrition and helping to resolve chemical subluxations like insulin resistance and metabolic syndrome. We also have a physical fitness department inside the office, basically because we just got sick of trying to teach trainers how to do what we wanted to have done with our patients. We decided, why don't we just bring physical fitness into our office as well? So we have small group classes on top of power plates and nutrition. Since then, I've started another practice in Denver, which I think I've got a couple of pictures inside here. It's a very small practice, kind of an incubator, just getting it going. And we've been open treating chiropractic patients in Denver for about 2 months, and are having our X-ray suite built out right now. So I'm pretty excited about that. So I want to tell you guys and give you an understanding of what chiropractic biophysics is. And it is a true postdoctorate specialty. All right, so there's a general certification series that's part of CBP that's 7 postgraduate courses. You can take them while you're still in chiropractic school. Some of you guys have already done that. After you finish those courses, which is about 90 credit hours, if you'd like, you can sit for a written and practical examination to try to earn your basic certification. After that, there's also an advanced certification, which is an additional 7 seminars. Again, 90 credit hours. And don't let the nomenclature fool you. The basic certification is quite advanced in and of itself. It's very detailed biomechanics of not only the spine, but more importantly, the central nervous system. And we're going to talk about that a lot today. The advanced certification series gets into more things like full spine deformities, scoliosis, and some extremely complicated aspects of spinal healthcare. right? So that's the CBP seminars branch of chiropractic biophysics. There's also another branch of chiropractic biophysics, which is our nonprofit research arm. This slide's a little bit old. There's only 131 studies on this slide, but CBP has published a little bit over 150 peer-reviewed studies at this point, validating our approach to how do we evaluate our patient's spine and their structural health, how do we quantify that, how do we fix that. And so we've got a lot of different research showing how we did that, and we're going to go through some of that today. First, I want to give you a little bit of an understanding of why is it that I like to practice CBP. All right, and so one of the biggest reasons is because CBP is an adjunctive technique. It's not as a replacement for any other technique. It's in addition to other techniques, which I really like. Because I remember when I was in chiropractic school, at Life West, you teach a bunch of different techniques. Gonstead and drop table and toggle and Nuka, all these different techniques. And I had a lot of my friends that were discussing about, well, what technique that they were going to do. And I never really understood that. It always made sense to me that, you know what, different people probably have different problems, and different techniques might be better for this person versus that person. And so I didn't want to choose just one technique. I wanted to learn all of them. And CBP allows me to do that because CBP is looking at a different level of things. It's looking at not just segmental subluxation, but what I call a regional subluxation, right? So it allows me to practice a lot of different segmental techniques. Personally, I do for my segmental techniques a lot of Gonstead, a lot of diversified drop table, and instrument adjusting. All right. Another reason I like CBP is because I like predictable, measurable, and repeatable outcomes. I'm a very analytic type of a guy, and when I sit down with my patient, I want to be able to tell them exactly what's wrong with them, exactly what kind of improvement that they should expect to see in a given time frame. And CBP's research allows me to do that very predictably. I'll sit down with a patient and I can tell them, look, in 36 visits, I expect to see X, Y, or Z, depending on their condition. I believe that we should always continue to grow and improve. I don't think there's any such thing as being a master of anything. We can always get better, right? And so when somebody tells me that they've mastered this technique or they're a master of that, in my head I quietly think to myself, isn't that sad this person has given up on improving? I think we can always get better. And CBP shares that belief. CBP is always growing, it's always learning more, and it's always changing. If you go to the CBP cervical rehab seminar this year and next year, it will be slightly different. There will be more information. We will learn something new. From when I first took it, which I've taken cervical rehab probably like 7 or 8 times at this point, it's completely different. We used to only have 7 different neck presentations, now we've got 14. So we're always learning and adapting and growing. I love that about CBP because there's some other techniques that I never understood. Why are we trying to keep this exactly how it was done 100 years ago? Shouldn't we be improving? I think a lot of the chiropractic pioneers were always striving to improve, and they didn't think that they had found the exact right answer. That's my personal belief. Also, the scientific nature of CBP has really helped me to bridge the gap between chiropractic and medicine. And I think that that's an important thing for our patients, right? Because medicine, though it is certainly overused, is extremely important, right? Emergency medicine, if it wasn't for emergency medicine, I wouldn't be here today. I'd be dead in a box somewhere, right? So emergency medicine has saved my life. And so I want to bridge the gap between chiropractic and the medical profession. And CBP has allowed me to do that. Because when I go in and I speak to some of my colleagues that are medical doctors, orthopedic surgeons, neurosurgeons, I've learned how to speak in their language, and I can explain to them through their language and through some studies what it is that I do, and they very easily get it. And it's because of that that I've started teaching at UCSF Med School and UCSF School of Pharmacology. I actually go into the School of Pharmacology and teach about how can you reduce medication dependency in diabetic populations through changing lifestyle. That's pretty cool. I never would have been able to do that if it wasn't for my background in CBP and the hard science that I brought with me to the vetting process when they were deciding if they were going to bring me in to teach that class. Right? And so that's something I love doing. Another reason I practice CBP, posture is a window into our spine. Right? Postural analysis is very detailed, and most people overlook it. But any kind of postural distortion that we see shows us a damaged, an injured, or a weakened part of our patient's spine that is shutting off the vital flow of communication from their brain down their spinal cord. Right? And so we know whatever shape the spine collapses or contorts into as we're walking around through gravity, or we're in all of these different macro and micro traumas throughout our life, whatever shape our spine assumes, our spinal cord is going to have to deform and deflect into that shape as well. Does that make sense? Right? And changing the shape of the spinal cord is going to have some different consequences. We're going to talk about some of those today. So, again, one of the biggest difference with chiropractic biophysics and some of the other techniques that are out there is that it's not looking at a segmental analysis. Right? It's not that CBP doesn't believe in segmental subluxation or think that we should address segmental subluxation. Right? So one bone in relation to the other displacing from normal, that's something that we need to address. But CBP doesn't teach you how to do that. We say, hey, there's a lot of techniques out there that show you exactly how to do that. There's validity to those techniques. Use which one that you think is the most appropriate. What CBP is more focused on is a regional analysis. How do the entire regions of our spine move and displace from their normal starting position? And really, isn't that how our spine works? I want you guys to do me a favor right now. Don't move any part of your body, but make L5 go PRS. How about don't move anything else in your body and make C6 go body left? Can't quite do that, right? That's not how our spine moves. Our spine moves in entire regions, and the segments that make up the different regions of our spine move inside of that global displacement. All right, so what we look at in chiropractic biophysics is structure in two different ways. We look externally at our patient's posture, right? So we want to look at the three major centers of mass: the head in relation to the rib cage in relation to the pelvis, and the pelvis in relation to mid-stance over top of the feet, right? And then internally, sorry, I hit the wrong button there. Internally, we're looking at spinal curvatures, right? So our spine should be straight from the front and have three opposing curvatures from the side. We measure and quantify those as we're working with our patients. All right, so question for you guys. Of the 9 different systems in your body, there is only one, your central nervous system, that is completely encased in solid rock hard bone. Why?
It's the most important.
It's the most important. Another reason?
Sensitive.
It's extremely delicate stuff, right? It's very, very sensitive. So it's completely encased in bone so that we can protect it, because it's controlling and coordinating everything, and it is extremely, extremely sensitive, right? If you guys bang your funny bone, what happens? It's not funny at all, right? These fingers down here, the ulnar nerve distribution, start dysfunctioning and tingling. What is that tingle? Somebody probably said it, I couldn't hear you, but. So that tingle is abnormal firing of the sensory nerves in your fingertips, right? You have more sensory touch fibers in your fingertips than anywhere else inside of your body, because you need to be able to touch and interpret, what is this thing? It's a lectern, that's what that is, right? But you don't need to touch and interpret things with your liver or your colon, do you? So do those organs have touch fibers that have that type of a sensation? Can they tingle? No, they can't, right? And so we want to look at the spine, because when we look at our patient's posture, if I see my patient has got a significant right lateral flexion of their head in relation to their rib cage, I know that inside they also have to have a right lateral flexion throughout their entire cervical spine. And then what does that mean to the spinal cord that's inside of that? right? The reason that we call this chiropractic biophysics is because it is physics applied to a biological structure. If you have a column that you bend over to the right, you're going to apply a tension load on the left side, right? You're going to elongate those nerves. There is no ifs, ands, or buts about that. That's just how physics works, right? And so when we see something like that in our patient's posture, we have to, in our head, see what's happening to that patient's spinal cord and their individual nerves. Now, question. If you had to prioritize, which I don't think that you have to, but if you had to prioritize, what is more important? Individual spinal nerves or the entire spinal cord? What would you have to say? Spinal cord, right? You absolutely have to say that because it's contributing to all of those nerve roots, right? So you probably ought to look at the shape of the spine and the curvatures and global displacements because they affect the entire spinal cord has to move around when we change the shape of our spine or we change our posture, right? An individual subluxation, a segmental subluxation is absolutely going to affect articular neurology. It's going to affect individual nerve roots, right? But when we have a regional subluxation, a whole region of our body that is shifted out of place, that's going to deform and deflect the entire spinal cord. Does that make sense? All right, so when we look at posture, again, what we want to look at is each region in relation to the region immediately below. So we look at the head in relation to the rib cage in relation to the pelvis, and then the pelvis in relation to mid-stance, both in the front and in the side view. When we are in that position, when we are aligned vertically with gravity, it takes less mental energy and less physical energy for us to negotiate gravity and for us to walk around. Right? It's like if I'm holding a stick in my hand. The straighter that stick is, the easier it is for me to balance, yes? The more crooked that stick is, the more I have to try to compensate for that, the more my muscles have to work to try to keep it up, and the more likely that stick is going to fall over, yeah? Falling over, that's like a slip and fall. Is that a problem in our elderly population? It's huge. What do we worry about if an elderly person over the age 65 falls?
Fracture.
Hip fracture. Why do we worry about that? Because they're going to die. Right? Statistics tell us that if someone over the age 65 falls over and breaks their hip, how long do they have to live? Do you guys know?
6 to 9.
On average, it's between 6 months and a year. Right? And so by being more vertically aligned with gravity, it's easier for us to negotiate gravity. It takes less mental energy for us to do that. It also literally takes less physical energy for us to do that. I want you guys to all do me a favor and put your hands above your head just like this, right? I'm going to use some techniques with you guys that I teach with my patients as well to get them to understand these things. I want you to imagine for a second that I just set a 12-pound bowling ball into your hands. Feel the weight of that. 12 pounds is fairly significant, yeah? Take that bowling ball and then hold it all the way out here. And imagine how much heavier and harder it got for you to hold that bowling ball up. How long do you think you could hold that bowling ball there before your muscles and your shoulders started to fatigue? Not very long. Would you possibly start getting some burning and achiness in those traps? Would you start getting knots in those traps? How many of you guys have knots in your traps? Right? So if I'm holding a bowling ball all the way out here, and my shoulders start to fatigue, and I start to get knots in my traps, could you massage those for me and fix the problem? No, right? Because I still have that bowling ball all the way out here. Certainly it's going to feel good, but it's not going to change the problem, right? And what else is about 12 pounds in the size of a bowling ball? Right? So people's heads are sticking way far out, and that's going to cause all kinds of different problems. We can explain that to our patients, and they understand it very, very easily. All right, so here's one of the ways that we look at posture through the posture screen app that you can get on your phone or your iPhone or whatever. Now, Cheryl here has some atrocious posture, yeah? Her pelvis is translated to the left, rib cage is translated to the right, she's laterally flexed in the left in her rib cage, and her head is laterally flexed to the right. Now, it's easy to see that right now because we're talking about posture like crazy, and I've got this grid system up here, yeah? But if those grids weren't on there, and we weren't talking about this, and you weren't like me and can't stop looking at posture, you probably wouldn't even notice that. If Cheryl was just in the line in front of you at the movie theater, if you noticed anything, you might notice that her purse and her shoulder was higher on one side, the side that she's holding her purse on. Can you think of any reason why Cheryl would not want to have her purse on her left shoulder? Slide off, right? She's got a slope on one side, she's got a shelf on the other side. Ladies, how many of you have a purse or a shoulder you prefer to carry your purse on? Or gentlemen, a single strap backpack? Do you have a preferred shoulder? Why? Because it's easier to hold it on that side because you have a shelf, right? There's all kinds of different aspects of things that are showing up in our life that are tipping us off that we've got these different types of regional subluxations, right? Another one, ladies, if you're wearing a skirt, do you ever notice that it starts to switch around to one side and a couple of times per day you have to straighten it out? Does it go to both sides or does it always go to the same side and you have to straighten it back? Always goes to the same side, right? Why? Because you've got a pelvic rotation, you have to take a longer stride on one side than the other, right? And these regional displacements cause a lot of problems. This is out of the American Journal of Pain Management, Lennon et al. Posture affects and modulates every physiologic function from breathing to hormonal production. Spinal pain, headache, mood, blood pressure, pulse, and lung capacity are among the functions that are most easily influenced by our posture. Blood pressure, pulse, and lung capacity. Are those pretty important aspects of our physiology? How are they influenced by our posture? Right? So most of us are going through our lives and gravity is constantly pulling us down, yeah? Gravity is relentless. It's never going to quit. And so most of us are going through our lives, and why isn't Spinal Man aging for me? Okay, well this should be a little video where this guy gets, there it is, finally. Whew. Hate technical difficulties. All right, so when your head comes forward like this, gravity's constantly pulling you and it's pulling you down further and further and further, right? And we've all seen these people walking down the street, right? Did these people wake up one day and they were just stuck like this and they couldn't get back up? No, it started here and they didn't do anything about it and gravity just pulled them down over time, right? And once you get down to this position, what's happening to your lung capacity? Right? Let's not even make it that far. If I go from normal posture to just here, what happened to my lung fields? Did they get bigger or did they get smaller? Smaller. Is that going to affect my lung capacity? Yeah. Right? My heart's sitting on the front of this column that is my spine, right? If I collapse this way, do I put more pressure onto my heart? Absolutely, it's physics. There's no way to escape that, right? So is that going to affect my blood pressure and my pulse rate? Absolutely it is. We know that it does, right? So what CBP is always looking at is how do we validate this thing called subluxation, right? And if you could get chiropractors to agree on a definition of subluxation, which is really hard to do, but if you could, you would probably get them to agree at least that bone out of place causes nerve interference, yes? Right? There's a problem with that because no one ever really very well defined what bone in place is. How can you say a bone is out of place if you haven't defined what in place is? All right? And so what CBP has done is looked at defining what bone in place is so that then we can look at our patients and see have their bones shifted out of place. Right? So we need a very clear definition of in place. And that was given to us by the Harrisons. Right? So Don Harrison was an interesting guy. He pissed a lot of people off. He was very opinionated. I thought he was hilarious. Right? But, you know, Don was an absolutely amazing man. Right? Let's think about this guy. He went through chiropractic school, got his doctorate in chiropractic, got out and thought to himself, wow, that was really cool. I've learned some amazing things, and obviously chiropractic is extremely powerful. But I'm trying to find bones that are out of place, and nobody ever told me what in place is. And so he thought, I need to understand this more. And so that he could identify and quantify in place, he decided he needed to have more information. So he went back to school and simultaneously studied physics, mechanical engineering, and mathematics. And while in full-time practice, got his PhD in mathematical modeling and his master's in mechanical engineering. I mean, can you think about how driven of a man that has to be? I mean, you guys are in chiropractic school right now. You plan on getting a PhD and a master's afterwards? No way, right? I mean, extremely, extremely driven man, right? And so he gave us the ideal spinal model, which we'll talk a lot about in a second. And then his son, Deed Harrison, has since taken on the mantle of CBP and started studying, okay, well, how do we restore in place? At this point, Deed is now the most published chiropractor in history, and he's a manuscript reviewer for Spine, the European Spine Journal, the Journal of Clinical Biomechanics, and all kinds of different journals are so impressed with the quality of his research that they've asked him to review other people's research. Right? There's not a lot of chiropractors out there as manuscript reviewers for spine. Right? So why do we need an ideal spinal model? Well, in all fields of physiology, no matter what aspect of physiology you're looking at, we have an ideal, an average, and a normal range, correct? Right? And why do we have those things? It's not that we think everybody should be ideal. Right? If I take your blood pressure and it is 125 over 82, am I worried? Not at all. Right? Because it's inside of a normal range. It's not that we think that somebody needs to have exactly 98.6 as their body temperature, but we know that we have these ranges of physiology that while we're inside of these ranges, the human body typically does very well. When we shift out of that normal range, the human body typically develops disease processes. Right? The same thing is true with the spine. So they wanted to identify and quantify what is an ideal position for the spine, what is an average position for the spine, and what is a normal range that when we know these bones are in these positions, in this normal range, the human body typically thrives instead of developing disease. Right? And so that's where the Harrison spinal model came from. What it is specifically, it's an evidence-based model for the sagittal plane alignment of the spine. It tracks the posterior longitudinal ligament from C1 to T1, T1 to T12, and T12 down to S1. Right? Why would we track the posterior longitudinal ligament?
Close to the cord.
It's the most closely approximates the spinal cord. Right? And so what they did is they looked at quantifying how much curvature should we have in these different regions. And it's based off of what is called a height to length ratio, right? The Harrisons weren't the first people to decide, hey, we probably ought to know how much lordosis somebody should have in their neck, right? There were other models out there before, but they were always proposed on what's called a uniform radius of curvature, as opposed to a height to length ratio. What would be the problem with just using a uniform radius of curvature?
What if it's not angle changes?
What if it's not a circle? Also, what if you have a patient that is 5'4" and you have another patient that's 7 feet tall? Right? That's why it needs to be a ratio of height to length so that we can match it to different size individuals who have normal anatomy. And that's important. If somebody does not have normal anatomy, they're not going to fit this. And we know that. Right? So if somebody has 6 lumbars, that's going to change how much curvature they should have in their lumbar spine. And we have an equation that we can plug in and find out what is that person's ideal and average range. Right? But we know if someone has normal anatomy, that they should closely fit this model. It's been studied in many, many different ways and been validated in tons of different research papers in a lot of different journals. This is just a few of them up here, right? Now, I don't want to just berate you guys with research, but I do want to give you a little bit of an understanding of how does a CBP researcher's mind work. So we're going to go through a couple of studies on how do we actually validate subluxation, because that's extremely important, right? There are people in our profession trying to say that subluxation doesn't exist, right? Right? There are all kinds of people trying to say that subluxation exists, so we need to be able to prove that it does. Now, there's different ways that we can validate it. In the cervical spine, we're going to talk about presence or predisposition to pain syndromes and increased tissue stress leading to DJD. Now, pain syndromes. Obviously, I know that chiropractic is about a lot more than just pain. Would you guys agree? Right? But does that mean that we should ignore our patient's pain? I know there are a lot of chiropractors that they don't like to even talk about pain because patients get so fixated on it and they want them to understand the whole health model of it. right? But the reality of it is that pain is a huge problem in and of itself, right? Pain is a predictor of depression. Pain is a predictor of dementia. Pain is a predictor of spousal abuse. Pain is a predictor of suicides, right? There's high correlations with that. So I don't think that we should be opposed to talking about pain, or we should be proud of how good we are at resolving it. Does that make sense? All right, so let's look at this study that was looking at the predisposition of pain with changes in shape of the cervical curvature. So this study had 277 different patients out of Macquarie University in Australia. And what we did, we took 277 patients and we measured the ARA of C2 to C7, so the global curvature of their cervical spine. We also measured anterior head translation, positive translation of the head on the Z-axis, and then we rated their pain scales. And we looked for, are there some statistical cut points that predict whether or not somebody is going to have pain just by looking at their x-rays. And what this paper found was that if you had a patient that had 20 degrees less, or 20 degrees of cervical curvature or less, they were twice as likely to have pain than if they had more than 20 degrees of curvature. More impactful than that, the odds that a patient had cervical pain if they had a flat neck or a neck that was curved the wrong way was 18 times greater than the patients that didn't have any cervical pain. That's huge, right? And this was true over all different ages, right? Didn't matter what age the patient was, if you looked at the shape of their spine, you could predict whether or not they had pain or not. This graph shows us that those 277 people, right? So this is called a dot plot. Every single one of these dots is one of those patients. So what we did is we measured the curvature of those patients, right? And then the top graph here, these people said, I have pain, and we measured their neck curve. These people said, I don't have any pain, and we measured their neck curve, right? So in statistics, what you're always looking for are statistical cut points that show us if you're above or below this area, we can predict something. There's a very strong statistical cut point right at 20 degrees right here. If you count up all of the dots that are at 20 degrees or below in pain versus non-pain, you find out there are twice as many up here than there are down there. That's how we can say if you have less than 20 degrees of curvature, you're twice as likely to have pain than if you had more than that, right? If you look at 0, there's a really strong statistical cut point there, right? What happens at 0? Look at all these people that have pain, right? Where they have no neck curve whatsoever. And if you count up all of the dots that are at 0 or below, look, there's only 3 in the non-pain group. Pretty interesting, right? There's 18 times as many dots here as there is there. Right? So it's a very good predictor. Just looking at the shape of somebody's spine, you could say, oh, this person has pain, or this person doesn't have pain. There's also something really interesting that happens right here between 30 degrees and 40 degrees of curvature. What do we notice there? People that have pain don't typically exist in that area, right? So there seems to be a protective benefit between 30 and 40 degrees of curvature. Pretty interesting, right? Let's look at another type of way that we can validate subluxation, and that would be looking at, is structure predictive of dysfunction and degeneration? All right, so in this study, what we did is we looked at the mechanical forces acting on the cortical bone in the vertebral bodies of 4 different neck shapes. So literally, we inserted sensors in the cortical bone of the vertebral bodies and measured the amount of force that was happening in patients that had a lordosis, in patients that had an S-curve that had a kyphosis in the lower neck and a lordosis in the upper neck, an S-curve that had a lordosis in the lower and a kyphosis in the upper, and then a complete and global kyphosis. So we looked at those different shapes and measured the force acting on those shapes and then charted it in this graph here. All right, so on this side of the graph, this axis here shows us the type of force that is acting on the cortical bone. This 0, this second line right here, that's neutral, no compression or no tension. Above 0 is a compression or a squashing load acting on the bone. Below 0 is a tension or a stretching acting on the bone. And then the 4 different neck curves are charted right here. The solid line down at the bottom is normal lordosis. What do we notice about the normal lordosis? It's 100% of that line is underneath zero. There is a slight tension load acting on the cortical bone of our patient's vertebral bodies when they have a lordosis. And then we notice anywhere there was a kyphosis in our patient's spine, it flips from being a lordosis to being a compression load, right? So if they had an S-curve, down at the bottom here are the vertebral segments, C2 to C7. If they had a kyphosis in their lower neck, they had a compression load there. If they had a kyphosis in their upper neck, they had a compression load there. If they had a global kyphosis, they had high compression loads throughout the entire cervical spine. Why is that important? Degenerative disc disease, right? What does Wolff's Law tell us? Bone remodels to stress, right? Bone remodels to the force that's acting on it, right? And so degeneration, we can predict where a person is going to degenerate. This video is a series of hundreds of different patients, or actually it's not hundreds, it's dozens of different patients, that all we did is we progressed a loss of curvature at the lower neck from being normal to being in a kyphotic position. So now that I've explained that, I'm going to start this over because I want you to notice in a lordosis, these bones are nice and square, the disc spaces are nice and open, right? And all we're doing with tons of different patients is we're just progressing a loss of curvature in the lower neck. So now it's starting to get kyphotic. What's happening to these bones here? Osteophytes, right? The bone spurs that you can watch appearing right there. Look at these disc spaces, how they're collapsing, right? Again, this is dozens of different patients, but it's lined up together. It looks like it's a time lapse of the same person, doesn't it? That's how predictable and repeatable this is. What causes degeneration is not age. And this is one of the things that I get into a big debate with a lot of my orthopedic buddies all the time, because I work with a lot of orthopedic surgeons. They refer patients to me. When I need a surgical consult, I refer patients to them. Luckily, not a single patient I've ever referred to them ever actually had to have surgery, because the surgeons that I work with, their goal is to try to avoid surgery because they know the statistics of how bad it works. But when we start talking about degeneration, especially with hips, they'll talk about how it's a normal variant of age. You guys heard that? You might have learned that in bone and joint if you guys take that class. And I always ask them, I'll pull out an x-ray, maybe their pelvis, and I'll look at one hip or another. If I had a cervical spine like this, I'd say, are you telling me that this joint is younger than that one? Right? Age is not a predictor of degeneration. Abnormal stress and strain acting on the bones and the discs and the joints is. It's pretty important for us to understand as chiropractors, yeah? All right, and again, changes in the spinal cord the spinal structure affect the spinal cord, whatever shape our spine deforms and deflects into, right? So when I sit down with the patient on day 2, and I'm doing a doctor's report with them, first thing I do is I show them a normal, healthy spine. And I explain to them, okay, this is a normal, healthy spine. This is the normal shape of the spine. When you're in that position, your structure is strong, your posture is erect. The weight of your head is distributed equally along the bones and the joints throughout this area, and your spinal cord, which sits right in the back of this curve, is in its nice, neutral, and relaxed position. Here's your x-ray. What do you notice? And the patients will tell you, the bones of my spine are out of place. Or they will say, my spine is bent the wrong direction. They can see bone out of place like that. And then you help them to understand, how does it affect the nervous system, right? So I'll ask them to do this, and I'll ask you guys. Everybody, do me a favor, put your right hand up just like this. Make sure it's got a nice curvature in it, just like the normal curvature of the spine should be. Right? The spinal cord sits in the back of that curvature, just like this piece of tissue at your knuckles sits in the back of that curvature. Grab on to that piece of tissue at your knuckles. Right? You can hold on to it, it's loose, it's pliable, you can move it around, yeah? That's your spinal cord. Hold on to your spinal cord for me and lose your neck curve and tell me what has to happen to your spinal cord. Stretch. Did everybody feel that? Did anyone not feel that stretch? Right? What we just experienced together is a law of physics. If you have a curved column and you make it straight, or you curve it the other direction, you apply a tension load to the side that used to be concave, and you apply a compression load to the side that used to be convex. It's just physics. You don't get to opt out of it. Right? So is the shape of your spine important? And patients get it immediately. They understand bone out of place and how it affects their nerves and their nervous system. Right? So when you see x-rays, you have to imagine what's going on with the spinal cord itself. Right? We got to see what's happening on an MRI. Right? If we have a normal curvature, the spinal cord's in a neutral position. There's the fluid on either side of it protecting it. If somebody loses that curvature, we know that it's going to elongate their spinal cord. It's going to put more of a compression load on those discs. They're going to start bulging out. It's just physics. There's no way around it. Right? There's a whole series of papers that Deed did talking specifically about the biomechanics of the central nervous system. Right? So we just talked about extension and flexion of the cervical spine. But what happens when you translate your head to the right, to the spinal cord? What happens to the spinal cord? When you rotate your head to the right, what if you translate to the left and rotate to the right simultaneously? What happens to your spinal cord? If we're doctors of the spine and nervous system, shouldn't we know that? Right? And so that's been very well researched and documented. It's very heady information, so we're not going to go through it. This is an introduction. That's stuff we go through in the advanced seminars. Right? But it's very important for us to understand what's physically happening to the spinal cord when it's in these different shapes. Because does nerve tissue like mechanical force? Not at all. It doesn't matter whether it's compression, torsion, shear, or any type of mechanical force acting on a nerve changes the way that it fires. Right? It changes nerve conduction velocity. And that's something that in CBP they're studying. Not just the shape of the spine and how do we restore it, but when the shape of someone's spine is displaced from normal, what does that do to nerve conduction velocity? And actually measure the nerve signal itself. Right? There's not a lot of chiropractors or chiropractic researchers out there that are studying actual nerve function. Lots of times we use indirect measurements, right? Like thermography, right? We're measuring skin temperature and we're extrapolating and assuming that that is measuring nerve function. And I'm not saying it isn't, but it's not a direct measurement of it. Right? So what Deed and the team of researchers are doing right now, and there's some really cool papers that are in review process right now that are showing that when you have a change of this cervical curvature, the nerves all the way down into your feet have a reduction of the nerve signal's amplitude, so the strength of that signal, and they have an increase in the latency, which is the speed slowing down. Right? So they've documented and demonstrated that changes in the shape of the spine slow down and weaken the nerve's ability to fire. Pretty amazing stuff, right? I think we should all be looking at that kind of thing. So again, you guys, at this point, you might be starting to see how normal posture and spinal curvature is our body's expression of three things: core strength, stability, and physical health. Right? When we lose the normal shape of our spine, it's going to lose the core strength, stability, and physical health of our body. And we can document that in a number of different ways. All right, so here is a lateral translation of the rib cage in relation to the pelvis. So what it looks like on the outside. Posture is a window into our spine. And any postural displacement we see shows us a damaged, injured, or weakened part of our spine that is going to affect not only the nerves, but also how is our body able to function. Right? What's this muscle?
Psoas major.
Iliopsoas. What does it do?
Trunk flexion.
Starts hip flexion, right? It initiates our ability to walk around. Right? Now, most people have no idea what core strength really is, right? But we need our core to be extremely strong. It's not just our abs, it's all of our axial skeleton and the muscles and the tissues that stabilize our axial skeleton. Right? And we need it strong because that's the basis of motion for every movement in our body. For the iliopsoas, it holds on to our lumbar spine and uses that lumbar spine as an anchor. It needs it extremely strong because it holds on as an anchor and then grabs your femur and pulls up towards the lumbar spine to initiate our walking around. Right? So we looked at Posture Man, who had a lumbar translation of his rib cage over to the side. Well, here's what it looks like on the inside. Right? If you have a shift of your rib cage in relation to your pelvis, which, by the way, about 2/3 of the population does, we know that that is going to cause some changes in the individual spinal bones as well. And what does that do to the iliopsoas on this side?
Elongate it.
It's elongated, right? Is there any way it's not stretched out? What about the iliopsoas on that side? Well, it's loose and flabby at the beginning. And if it remains that way, it becomes tight and constricted over time. There's no way around that. Is that going to affect this person's ability to walk around? Might that make their skirt switch over to one side? Right? We know that this is a predictor of disability. Right? What about the nerve that's coming right from here to the ascending colon? What is happening to that nerve? It's being stretched. It's physics. There's no way you're not stretching that nerve. Right? Does the ascending colon have to touch and interpret anything? No. So can it tingle? No. So how do you know how it's functioning? You got to talk to your patient. Right? And anytime I see this, I sit down with the patient again and I say, look, I know that this is sometimes awkward to talk about, but I'm your doctor and I know you're dealing with something. Is it constipation, diarrhea, irritable bowel, ulcerative colitis? What are we talking about? Because if their rib cage is sitting over to the side like that, that nerve has got to be stretched out. And invariably they're like, yeah, doc, it's constipation. They don't want to talk about it. But if you know biomechanics, you know what's going on with the spinal cord and the spinal nerves themselves. All right? Also, changes in position of the regions of our spine, rib cage in relation to pelvis or head in relation to rib cage, we know that those are going to cause segmental subluxations as well. Right? Remember, we can't make L5 go PRS by itself. Right? When we laterally translate our spine, how do we do that? If we have a displacement, here's A to P, here's P to A, right? If we have a left translation of the rib cage, the only way that is possible is if the lower lumbar segments laterally flex towards the translation and the upper lumbar segments laterally flex away from it, right? It's the only way it's possible, right? And so global displacements are comprised of segmental displacements, right? So if you didn't know this stuff, you didn't understand it, you were never exposed to it, you never studied it, and you were just doing motion palpation on L4 and L5, you think you might feel an asymmetry of motion there? Right? And so you might think to yourself, okay, well, it's not laterally flexing this way, it's not rotating that way, so it must be stuck in the opposite position, right? That's what we do in motion palpation, yeah? We assume that we found a displacement. When we're doing motion palpation, we don't find a displacement, we find an asymmetry of motion, yeah? Right? So if you were just working on those segments and you were adjusting them, but you weren't changing the fact that the rib cage was sitting over top of the pelvis, might that explain why the patient always has an L5 subluxation every time they come in? Maybe. So we look at biomechanics in all kinds of different ways because you have to identify and understand what normal is before you can ever identify what abnormal is. Right? So we know if you're anteriorly translating your head, how do you do that? With keeping your eyes neutral, the only way you can do that is by flexing your lower cervical spine and extending your upper cervical spine. Right? If you posterior translate, we know you have to be extending your lower cervical spine and flexing your upper cervical spine. Right? And is that going to change function? Everybody sit up nice and straight. Make sure your head's over top of your rib cage. And I want you to rotate to the right and to the left. Notice your range of motion. All right? Now, anteriorly translate your head forward and rotate to the right and left. Did that just change the range of motion of your neck? Absolutely. Structure dictates function. Right? And so we need to understand these things. Also, we should probably understand the limits of translational motion. Have you guys noticed that you were only ever taught 50% of human range of motion? I never noticed that when I was in school, but they only taught us 50% of it. Right? Think about it. When you taught range of motion, what are you taught? Flexion, extension, right? And that's rotation around the x-axis. You're taught lateral flexion, which is rotation around the z-axis, and you're taught y-axis rotation. But should we know how far a person should anteriorly translate their head? Or laterally translate their rib cage or their head? Right? That's ignored in most musculoskeletal healthcare, right? But the Harrisons have studied it and quantified it. A 5'9" individual can anteriorly translate their head by 75 millimeters, right? And we know what that would do to the cervical spine and the different segments. What about if we translate our rib cage forward? How do we do that? If you anteriorly translate your rib cage forward, we know that you're going to flex or make the sacral base steeper. You'll have flexion in the lower lumbar segments, and you'll have extension in the upper lumbar segments. We know that, and we've quantified it. If you posteriorly translate your rib cage, how do you do that? What happens to the segments of your spine when you do that? As chiropractors, should we know? Right? Because when you posteriorly translate your rib cage, we know that's going to reduce your sacral base, it's going to extend your lower lumbar spine, it's going to flex your upper lumbar spine, and it's going to increase the global curvature of your thoracic spine by a specific amount. And when you know normal, you can identify abnormal, right? So, limits of translational distance on a posterior translation. You can translate your rib cage back about 75 millimeters. We know when you do that, you should decrease your sacral base by approximately 15 degrees. You should increase the RRAs, relative rotation angles, of your lower lumbar spine, decrease the upper lumbar spine, and the thoracic curvature should increase by about 13 degrees. If you know normal, you can identify abnormal. All right, so here's a patient from my office. This is a 15-year-old girl who came in, and these were her initial x-rays. These were her initial symptoms. When she came in, she was complaining about lower back pain, and so that's why her parents brought her in. But we don't stop there. We do a very detailed review of systems with all of our patients, and we find out that actually she's got a whole host of problems that she's been seeing a neurologist about for the last year and a half, and the neurologist can't figure out what's going wrong with her. Right? So here are her symptoms. She's got migraine headaches, neck pain, dizziness, visual disturbances, numbness and tingling in both hands, so she's losing sensory function of those nerves. She's got weakness in grip strength on the left hand, so we know where she's losing motor function of those nerves. She's got coldness in the left hand. We know she's losing the peripheral circulation into that hand. She's got mid-back pain, pain in her ribs and chest, heartburn, heart palpitations, shortness of breath, muscle cramps, and involuntary breath patterns. That was a really weird one. Every once in a while, she would get this situation where she would just start taking these gasping breaths, and she could hardly breathe out, and it would really scare her. And really, when it happened in my office, it scared the crap out of me too, because I had never seen that before. And I've been working with her a while. I knew she'd been seeing a neurologist. When that first happened in my office, I was like, I'm finally going to talk to this neurologist, because I'd been trying to get in touch with him, but I was going to track him down. When I finally got in touch with him, I asked him, what the hell is that? They said, I don't know, I've never seen it before. I'm calling it an involuntary breath pattern. I said, okay, it's an abnormal diaphragmatic spasm. Sounds good, let's go with that. And so I sat down with her parents and I said, look, just like your neurologist, I don't know for sure what is causing that, but I do know that this white thing right here, that's your daughter's diaphragm. It inserts on her lumbar spine, which should be sitting way up here on this green line, but it's all the way back there. That's a problem in and of itself. Let's work on that and see what it changes with those breath patterns. Maybe it will change it. And so we go through a series of care with her, right? So first, before we do any treatment, we have to look at and what is really wrong with her, right? So we measure the amount of curvature in her thoracic spine. Globally, which is an absolute rotation angle, she should have about 44 degrees of curvature. She's 15 years old and she's got 71 degrees of curvature there. Right? We also look at it segmentally as well. Right? We also look at her lumbar spine. And we look at global changes normals and hers, we look at segmental and quantify those as well. Segmental subluxations we want to quantify. She's got posterior translations of L3, L4, and L4, L5. Right? She's got a 300% loss of the normal curvature in her thoracolumbar junction. And she's posteriorly translated 62 millimeters. All right? So now that I know what's going on with her, I can compare it to what I know to be normal. Like I told you guys, a normal 5'9" individual, she happened to be 5'8", pretty darn close. 75 millimeters posterior translation, we would expect to increase the thoracic kyphosis by 13 degrees, so go from 44 to 55. We would expect the sacral base to reduce by 15 degrees, so go from 40 to 25. And then I can look at her and what's happening with her. Well, she's gone backwards by 62 millimeters. That's about 83% of max. And so I can do a quick calculation and say, if her spine is behaving normally, she should have a 10-degree increase in her kyphosis and a 12-degree reduction in her sacral base. And then I can look at what does she actually have. Her thoracic spine is a 71-degree curvature, right? So that's almost 3 times as much curvature in that area that she should have. And in her sacral base, she's got 38 degrees. It's only 1 degree off instead of 12 degrees off. And so then I can very confidently sit down with her parents and say, you're wrong. It's not that your daughter's lazy, because they're saying she's got lazy posture. She just won't sit up straight, and they're berating her about it, right? And that's what's causing your lower back pain. It's just because you're lazy and you won't sit up straight. And I can sit down and explain, look, she can't do it. Her spine is injured. We know exactly what's going wrong with it. Do you want to fix it? And they say yes. And so we go through a series of care with her. So in chiropractic biophysics, we do segmental adjusting, that you use whatever type of segmental adjusting technique you feel appropriate, and then we do regional adjusting as well. We give patients mirror image exercises. So if she was posteriorly translated and she was flexed in her rib cage, so I gave her exercises where she was anteriorly translating her rib cage forward. I gave her exercises where she was extending backwards and really strengthening those muscles, right? Because she's got bones that are out of place and they're causing nerve interference, and I want to get those bones back into place. So you might call me a mixer because I'm giving exercises, but I think this is a form of an adjustment because I'm putting those bones out of place back into place. All right? We don't just do exercises, we want to do mirror image adjusting as well. Again, her rib cage was posteriorly translated and it was flexed, so we anteriorly translated and we extended and we put a drop through that area. Right? And what we're doing with the mirror image adjustments, again, it's taking bones out of place back into place, and we're changing the way that the synapses are communicating with those muscles. Right? Because the way that she's set up right now, when we took those x-rays, when we took her postural analysis, we had her close her eyes, shrug her head, nod her shoulders, and come to whatever she feels to be nice, neutral, and relaxed. We do it with every single patient, and we keep their eyes closed. Why?
So they don't see.
What am I measuring when I'm measuring posture? I'm measuring proprioception, right? She's thinking she's standing straight up and down when she's really standing like this, right? And so that's what her brain is interpreting as being neutral. And so we want to change those synaptic pathways, and one of the ways that we do that is through the mirror image adjustments, right? She's also got a lot of ligaments inside of her spine, yeah? Right? And though innate intelligence is an amazing thing, it is bound by limitations of matter, yes? Right? And ligaments are what are called viscoelastic structures. So elastic, if you just put a force through it really quick, it stretches and then it goes back to where it was before. That's a limitation of matter. We know that if we want to elongate those ligaments, we have to put a sustained load on those ligaments over time. Right? It's like if I'm going to stretch the ligaments in my legs so that I can do the splits, right? Can I just jump down and do the splits once? Absolutely not, right? That will hurt. So what do you got to do? You got to get into a position that's, hey, that's a little uncomfortable, but it's tolerable. You'll hold that for a little bit. It doesn't hurt anymore. It's not that uncomfortable. I can go a little bit farther. Do it day after day after day. Eventually you can stretch out those ligaments and do the splits. Right? Same thing is true with what we're doing with traction. And again, in my opinion, traction is a form of an adjustment. Right? If a subluxation is a bone out of place causing nerve interference, then an adjustment is a force being put into the spine for the reason of putting the bones back into place to reduce nerve interference. Does that make sense? Right? So that's what traction is doing. It's a form of chiropractic adjusting that takes place over time. Right? So her rib cage was posterior and it was flexed, so we translate it anterior and we put it into extension. We also, because she was so young and flexible, we knew there was a really strong neuromuscular component to this, so we also put her in a dynamic brace. Right? So it's very similar to this, but we bunched all of these straps up right into that thoracolumbar junction where she was really, really posterior and flexed, and had her stretched into this position, and then we put her on top of a power plate, whole body vibration, flooding her body with mechanoreceptive activity while she's in this opposite postural position so that we can retrain the synaptic pathways over time. Right? It's called neosynaptogenesis. Right? And then we take an x-ray and we see how did we do. Right? So here's where she was 3 months before we started with her, really posterior and translated, and really flexed forward. Here's where she is afterwards. Right? And then we go through and we measure it, and we also have her measure all of her subjective complaints. And she says she had 100% improvement in dizziness, visual disturbances, numbness and tingling, weakness in grip strength, the coldness, the cramps, 90 to 95% improvement in all of these different conditions, 80 to 85% in those. Pretty incredible. Right? She did some amazing work. So, what technique should I practice? Whatever's the most important thing that's going to help that patient. Right? To me, I don't think that we should be loyal to a technique. I think we should be loyal to our patient and make sure that they get whatever technique is the most appropriate thing for their injury. Right? And so, I work a lot with other chiropractors. I know a lot about upper cervical care, but it's not my specialty. If I run into a patient that has a very significant upper cervical problem, I co-manage with one of my colleagues, right? We say, okay, you do the upper cervical adjusting and I'll do the mirror image exercises and traction, right? And we work together. I think that that gives our patients the best possible results. Does that make sense to you guys? All right. So, again, CBP is looking at regional displacements and how do we address those in addition to the segmental subluxations. All right, so where would we get started if we wanted to learn these things? All right, the first thing is you've got to get to the seminars. Right, CBP teaches seminars on a regular basis. They have a week-long certification series. There's one happening next March, from March 26th to April 2nd. I know that Deed typically times those with schools' spring breaks. Right, so if this isn't your spring break this year, he'll probably do your spring break next year. Right? But if you can get to that seminar, definitely do it. The rest of the 2016 seminar hasn't been released yet of what those dates are, but you can always check it on idealspine.com/events. Right? And then, I'd really suggest you guys join the CBP club community here. Right? Make sure you guys are going to club and practicing on each other, working on how do you actually analyze a patient's posture. It's not very easy. I'll tell you, anybody that says that postural analysis is easy has no idea how to do it. Right? So you guys got to practice those things. So go to club, engage on the CBP club Facebook pages, and ask questions. Right? One of the things that I do for Deed is I monitor the CBP club Facebook pages at all the different schools. And if you guys put a question up in there, usually within that day, I'm going to give you the answer. Right? So if you have questions about this, engage in the club. I also would like to ask you guys to give me some feedback on that website, on the Facebook page. If you guys liked the lecture today, please let us know. I'm trying to get Deed to keep sending me out to the schools. Did you guys find any of this valuable? Yeah. I'd like to do more of this. Very recently, last month, I was at Life University, and I got to stay there for a couple of days. We did a talk like this, and then on the following day, on a Saturday, I did a mini seminar for everybody, and it was a club fundraiser. Right, so I'd like to do that for you guys next year, if you guys would be interested in that. Right, so if you guys could do me a favor and go make sure that you're on this page and give us some feedback about this so that Deed thinks it's valuable and keep sending me out to the schools. I'd appreciate that. And then the last thing that I want to leave you guys with is never leave your patients subluxated, right? It's such an important thing that most people are not looking at. So many chiropractors aren't looking at the shape of the spine. and these regional subluxations. And it's not that segmental subluxations aren't extremely important, they most certainly are. But I think that at this point, you guys will probably see and agree with me that, you know what, if the person's got regional displacements, their spinal cord is out of place too. And it's something that we ought to fix. All right, so that's all I got for you guys today. I'm going to stick around for a while. I'll answer any questions that you guys have. I hope you join us for Spine and Wine at Dr. J's office. All right, so thank you guys a lot for coming. If you have any questions, please come ask me. Are there any questions while we're as a group? Man, I'm good. No questions.
Did you want to go over any of those?
I mean, go over them? It's kind of hard to, I mean, you like what they are or how